Welcome to Care Transitions Today. Our podcast is centered on case management and transitions of care. It's presented by the American Case Management Association and underwritten by the Pfizer Foundation. I'm Deb McElroy, your host, and in today's episode, we're going to be talking about the payer perspective as it relates to the impact of COVID-19. And I'm delighted today to welcome our guest, Lynn Bree. Lynn is a healthcare industry executive. She currently serves on the National Board for the American Case Management Association. Lynn has a great breadth of knowledge and deep experience encompassing quality improvement organizations, utilization management, case management leadership. So the experience within the managed care industry, healthcare, and integrated healthcare delivery systems. So Lynn, I'm going to pass it to you and give us a little more detail on your background, and then maybe just a bit of a framework on our discussion today.
Thanks, Deb. And thank you so much for giving me an opportunity to discuss just a few topics from the payer perspective on the pandemic. You know, as we all know from every aspect, this is quite a discussion topic, and we could go on for quite a long time, but we'll limit it to about an hour or half hour, whatever time we have. What struck me most when I was asked to speak about this is reflecting on our history. When we look back through time, rapid change and leaps in technological advancements and dramatic shifts in social norms were often spurred by events or an event that acted as a catalyst, like the pandemic has. And this causes the sudden disruption of our normal. But it also fosters rapid change and innovation and, of course, heightened anxiety because we all deal with change in different ways. COVID-19 and its impacts on every level of our global society and our responses are really in flight when you think about it. They're being formulated as we're going from day to day, month to month. But we're already seeing that high level of science, innovation, social change that we've experienced through history when faced with catalysts. So I'm happy to have a discussion today that kind of brings that lens into focus from the health plan or payer's perspective. So I'm excited. So let's get started.
It's great. And this is honestly a great follow-up session to a couple of sessions we've had previously where we talked quite a bit about some of the activity on the CMS side where there were waivers created, and some relaxation of rules. And so what I'm interested in is how has that impacted, how has COVID impacted the health plans as it relates to, maybe things that you changed in the moment, any rules that were relaxed in the moment to help support your members as they're navigating this environment.
Sure. So what a lot of us, as with most organizations, the payer or healthcare industry, from the payer's perspective, there are associations. And much like the American Medical Association for Docs and the AHA or Hospital Association for Hospitals, there's a National Payer Association. And it's called AHIP, AHIP.org. And the reason I bring that up is that's a website for the payers, and there's some top issues on that website that talk about the dialogue with all the payers, in addition to Medicare and Medicaid discussions. Some of their top issues that are on there are opioids and high-priced drug concerns, and of course, COVID. So there are 63 resources listed under COVID on that particular website, and how payers are responding. And so it's a really excellent resource to kind of see all the payers from A to Z and what they're doing about relaxing rules, what they're doing to be out in the communities, how they're responding. So it's a really great resource. I did post some of the examples from multiple payers off of there, as well as my own experience But some of the examples were accelerating payments to providers. There was a lot of concern when they shut down on their financial well-being. So some of the payers were accelerating their payments to the providers that they have, extending all previously approved prior authorizations. The payers kind of jumped on that. CMS and the state also did, but it kind of takes a little while for that to trickle down through as a regulation, so to speak, or a waiver. But most of the providers jumped on that as well, on authorizations. Many enabled providers to be paid for the same amount for servicing members by telehealth as opposed to face-to-face. And that I think is one of the biggest innovations that's coming out of COVID. We pivoted rapidly to telehealth. CMS and our state guidance also shifted some of the barriers that we were experiencing in getting telehealth on the government space. And so we've been very carefully messaging that we'd like that to stay as an option for treating our members, patients, because we find that bringing the service to the people in their homes is being much more effective, especially in the current environment. We expedited credentialing. Some of the payers expedited credentialing to ensure that providers are able to see members for any healthcare reason. And when we say that, sometimes the Medicaid space is there's certain hoops you have to jump through as a provider to get credentialed or certified under Medicaid. What we saw during this time period is the states saying if a provider was already credentialed or certified under Medicare, that they would just acknowledge that for a period of time. And so that helped us be able to open up some capacity. We, of course, saw extending drug refills from 90 days or from 30 days to 90 days to 100 days, waiving early refill limitations was also another area that was changed and adjusted. Not requiring that face-to-face visit with physicians to authorize initial prescriptions of durable medical equipment or disposable medical supplies. So those are a couple of examples of how we saw payers pivoting, working with our government regulators as well to affect change. So hopefully that answered your question.
Yeah, it did. And again, when I think about the extension of drug refills, which is always a challenge, and especially with folks being able to get out, and also expanding capacity with getting folks, as you said, credentialed or certified. I think those are critical. I just want to dig in a little bit more on the pre-authorization or the authorization needed, because one of the things that happened on the CMS side is they were creating that waiver to expedite and not have any penalties around payment for folks that weren't in the acute care space, 3 midnights. So did the health plans just simply follow what CMS did, or were they trying to create some specific benefit to their members so that they could get them through the healthcare system more readily?
The payers who operate as contractors with CMS and Medicare and Medicaid follow the government waivers that are initiated as soon as they come out, and that refers to the no medical necessity authorizations for SNF admissions. And also, there was also a CMS qualifying MDS, minimum data set assessments, for 120 days. So being in a government space, you follow all those guidelines as well. I think what we saw in the circumstances, at least in my experience, as we were trying to get folks to the level of care that they needed to be at, wasn't so much that authorizations were the barrier with SNF, custodial care, special or skilled care. It was the willingness of the facilities to take the discharges. Mm. And so, and I might mention this later too in another aspect, but when we look at how did we handle our emergency preparedness, and what did we put in place in our infrastructure for healthcare, we we rightly so had a lot of interest and a lot of activity around how to create those ICU beds and how to create that capacity in our ERs and our ICUs, and even, dedicated COVID hospitals versus dedicated non-COVID hospitals in some situations. But we really weren't prepared to deal with that discharge to skilled. So when we look at that as an industry, not just as a payer, but providers as well, how do we address the fact that you might have not needed an authorization to discharge a member or a patient to a skilled nursing home, but the skilled nursing home wasn't going to be ready to take them. So where do you go?
Where do you go?
Where do you go? So what's our alternate placement for those members? Hospitals being opened up in stadiums. Maybe we needed custodial or skilled care in stadiums. That's a thought. But that's primarily where we saw difficulties around our skilled nursing facilities or custodial care levels. It wasn't so much an auth or waiving an auth or doing anything like that to facilitate the transfer. It was getting the acceptance on the other end.
Yeah, and I think that's significant, and as you said, has implications for the future. So barriers that we recognized and tried to navigate before maybe weren't the barriers that we actually saw.
So from a payer's perspective, you were looking at what was the level of care that person needed. And if we couldn't get them into SNF and the hospital needed those beds, what can we wrap around that person to perhaps allow them to go home with more care, more services, more resources, those kinds of things, was really where the thinking had to go.
Yeah, that sounds good. So I think you alluded to this before, but again, would like to just drill down specifically on that point. There were new rules on the CMS side for telehealth or telemedicine. And certainly that was something that occurred on the payer side as well. So anything in addition that you, were there new rules? Are there things that you see occurred now that was significant change that will apply down the road?
Well, the new rules provided an acceleration in telemedicine and telehealth opportunities in the government space. It was very much more advanced in the commercial space in comparison. So advancing these services for those who are on government programs was welcome. From a payer perspective, and in my own opinion, the relaxation of these restrictions on the originating site was really what one of the biggest barriers were on telehealth. Allowed us to bring the services to the member where they live or where they might need us to bring that service to. So in the past, we were always limited by what they called the originating site. It had to be in a clinic. It had to be, in a provider building of some kind. And that was one of the barriers that we were having. So this is critical at a time of limited physical access to open up the doors on telehealth. So increasing the services, the provider is providing more. In some payers, they're providing more than 20 behavioral health provider organizations with technological support and resources. Some of the payers are, such as the computers and the cell phones to make that telehealth happen. So you see some of the providers looking at their geography and their population and seeing, okay, we've got an open door more to telehealth, but yet we're still hampered by the hardware. So they are reaching out and working with communities. I've seen that in several areas of the country. Some providers are also offering data plans and cell phones to their Medicaid members who don't otherwise have the capacity to contact their provider for virtual visits. And you see this primarily being focused on behavioral health, small rural communities, remote areas of the state, again, where behavioral health is a real challenge. It's a powerful tool in the toolbox of behavioral health, telehealth is. So as a provider, I think that they also are opening up their mindset on telehealth and televisits. As a patient myself, I've taken full advantage of that. But you saw that slowly get amped up. They slowly got their video technology going. And I really don't think we're going to be looking back as we go forward as a healthcare industry. I think telehealth is one of those innovations that this catalyst propelled into how we do care.
So, and honestly, again, through the podcast, we're seeing that theme, that the necessity of the crisis has opened doors that we were knocking on for a while. You talked about emergency preparedness. So just to revisit that for a minute, you alluded to, do we need to think differently? Did we need to think outside of the acute care or hospital space and more about what comes next? I guess as you're seeing what your industry is doing, is there anything that you're taking from this current crisis and knowing you have to plan for going forward? Were there any unexpected partnerships with public health or with maybe other community partners that you're seeing evolve?
I think it was more the level of partnership was changed, the level of collaboration. We saw some shifts in that, especially with our regulators. A lot of folks, as we tried to work through what's next, be it within my own plan or company nationwide or our community resources, we kind of got a much more collaborative approach to problem solving. And I think there was a lot more listening. As everybody was able to bring to the table their barometer of what was going on out in the community and what people were dealing with. And so there was a lot of value in listening. So I think some of those partnerships that we saw with providers and payers and the state coming together was really, really key. And it had gotten in the throes of what was March and April. You saw we were on calls with our states probably at least twice a week, if not 3 times a week. All of the payers, and I'm pretty sure all the providers were as well. And so that was a very collaborative. I mean, we would hear what the regulators were changing and adjusting on waivers and rules and transportation and things like that. But we also were being asked, what are we hearing? What do people need? What do we think? So a lot of that was just a different environment, a better exchange.
Yeah, I love that. It's just a deeper level of something that probably high level existed. So we have now understood this is a marathon, not a sprint. And do you see, I guess just a quick question, do you see that cooperation continuing? Do you see, some of those deeper collaborations and partnerships being more hardwired going forward?
I think so. I think people look at what came out of those with much appreciation on the open dialogues that were going on. Another area that was phenomenal was the science. When you looked at, the Johns Hopkins website, they were pulling in from all over the world, and it was a daily feed and an exchange. And that particular site was pretty much kept pretty pure science-wise. But that's where you saw that innovation and that collaboration and that sharing of experiences and what people were seeing and how things evolved through basically February to now. If you would have told me as a nurse that, you were going to treat somebody with respiratory difficulty and have them be face down, I would have said, you got to be crazy. But as we saw science evolve and everybody sharing their experiences, at the regulator level, at the provider level, the payer level, and the science level. I mean, as you step back, that was just very inspiring to watch.
Yeah, agreed. So I think that's a great segue. So how do you see, as an industry expert, the health plans helping to assist, that's sort of the system level stuff, but at the member level, as you're looking at your health plan members and obviously the providers as well, specific interventions that occurred or are occurring that you think are worth highlighting?
And there were quite a few. A lot of innovation going on there as well. A lot of outreach. I think we'd probably need another session just to do justice on this question. As most of us have witnessed, there's been a kindred level of that partnership that we talked about, and that collaboration around scientific global communities, all industries. I mean, when you saw the car dealers making ventilators, and of course the local communities that we live in. Health plans are working every day to assist all of our communities because we live and work in those as well. I can highlight just a few things that have come to my knowledge and awareness from payers across the country, providing home delivered meals to members that are in need of that at discharge. A lot of payers were offering that. Care coordinators outreaching to members in active case management, the people I have on my caseload, as well as those that are identified as potential high risk. We were running lists looking at members that had the top 5 diagnoses that the CDC came out with. We were focusing on our members that were in food deserts. To make sure that they had access to food and knew, and all of these contacts that we were making, we were talking to them about COVID and symptoms and what to do. Hot spots for COVID, we saw those move in the city that I live in. We saw those hot spots move around. And so we were outreaching first to the north, then to the south. So we were all over the place as far as trying to make sure we were getting in front of the members and that they had what they needed. For many in healthcare, provider and payer alike, it can be particularly challenging to get patients, members to answer their phones so that you can help them. And I get that. I mean, I get over 5 robocalls a day. So for those with limited minutes, they are understandably selective on who they're going to spend those minutes talking to and how they're going to pick up that phone. I can tell you of note that during the months of the deepest isolation here, March through April and even into May, many were answering their phones. Members were so grateful for the call, and that's what we were hearing. We were used to what we call UTC, unable to contact. They were picking up the call. They had someone to talk with about what they were facing, what they were worrying about, strategizing on options for what their particular needs were. Was it food? Was it transportation? Was it just somebody to talk to? So they were picking up their phones, which was a big change. Many payers were on multiple standing webinars, as I talked about with the regulators, not only for communications of what Medicare and Medicaid were trying to communicate out to us on regulations, but also to collaborate. What are we hearing in our communities? What are the unmet needs? What are the barriers people are having or that our members are talking to us about so that we could relay that to the state? They wanted to know, the state wanted to know, what are we doing as payers? They wanted us to be able to share best practices. And then what did we need from them? So those calls were happening twice a week. And there were numerous WebExes and webinars offered in between there on specific topics. So you saw this real environment of collaboration. Additionally, again, if you go back to that website, I could point the listeners to that ahip.org. You can see that payers across the nation were contributing millions of dollars to food banks, donating PPE to free clinics, food banks, and shelters. Innovation on connecting was prevalent with tools for members seeking information about COVID. So a lot of folks were putting out teledoc handheld applications on their phones so that they could do checks, get in contact, link them to call a nurse, and when to call their providers. It was just the tip of the iceberg on payer initiatives on how they were partnering with their members. And that website that I gave you will just, I mean, it's very, very long because it does do all the payers alphabetically, but there's some incredible things going on, and it continues to happen.
That's good. And I
see a lot of grants being awarded too out in the communities.
For the grants are for organizations.
Payers are putting grants out there for community services that are struggling. So they'll award grants in different areas of the community that have a need. So you see that going on across the country.
Okay, good. So I'm curious, as you were, you're talking, there's a lot of member dialogue here. Probably it sounds like more than the norm. They obviously had questions about, what do I need to pay, and do I have to pay for the test, and do I have to pay for an AED visit? Those basic questions, which I know you can answer. But I'm also curious, did you see a shift in how you needed to think about some of the folks that you normally worry about? I would think with chronic disease, your heart failures or diabetics, or those folks that, are a population that I would think a health plan focuses in on. So what kinds of questions and what kinds of interventions did you provide?
Well, I think the biggest thing on my mind right now is more around, so we did outreach on our chronic condition members, certainly targeting the top 5 from the CDC originally, but our other members that are at high risk. What's of concern is the delayed care now. What is going to be the impact of care that has been delayed? And there are people that are not comfortable yet going into physician offices, and there are physician offices that still aren't open. Or they're open limited. Spoke with a provider today where they're doing only well in the clinic. They're allowing people who are coming in for well checks, immunizations, follow-ups, those kinds of things. Anyone who's symptomatic of COVID or something else is not coming into the clinic. They're doing televisits, or they're directing them to a tent out in the parking lot type of thing, where they're trying to keep their building preserved for the clean wellness visits. Because what we're going to see here is immunizations that have been delayed, follow-up visits and management of health that's been delayed. And so if somebody typically sees their physician 3 times a year and has gone now without any visits since the beginning of the year, we're going to start to see the ramifications of that. And so that's our biggest concern, is finding out what's the capacity of the providers, what are they able to see and not see, and then how do we reach out to our members to make sure that they're maintaining their health and addressing things before they get out of control. So that's really where the onus is going to be as we come out on the other side of this. We're going to see probably the impacts of delayed care rippling for years, but we're going to have an interesting 2021.
Yeah, great point. And as you think about the more short term, so we're in September right now, right? And what is traditionally a ramp up for a flu season, and from the health plan perspectives, what kind of strategies are you putting into place to prepare for these next 6 months? Because we didn't navigate exactly these months last year, so it is going to take us into 2021 for sure.
And it is going to be that big push on those flu vaccines. To the point where I know in my own particular plan, my plan president will be having a recorded call that goes out to all of our members. Please get your flu shots, because you're going to see that tandem risk that's coming in from COVID and the flu, and we're just starting now to see what's happening at the colleges. So where is that going to be this fall with the college campuses and those kinds of things? So really a huge push on flu vaccines. And so we'll be really pushing our members on that and calling our high-risk members. There's always those stalwart diehards that do not want to get their flu shot. So we will certainly be putting them on the top of the list. But I think that's where you're going to see the biggest push this fall is to try to make sure that we don't get slammed with a flu season on top of the COVID. So when we look at what's coming down the pipe, we're all researching that. We're watching and reading what's coming out in the industry. And I did recently look at a white paper from Change Healthcare that was talking about that very thing. And we're going to see, we expect the new face of Medicaid they talked about. When we start to see the unemployment and the loss of jobs equate to people coming onto the Medicaid program. They had insurance, perhaps. They had employer-sponsored insurance, perhaps, and they were getting care. And now we're going to see those folks coming on to Medicare or marketplace subsidies. They're going to qualify for marketplace subsidies, possibly. And we're going to see a different population entering into the system where they're healthier. Sometimes they're healthier, they've had care, maybe the care that they're going to be qualifying for now has benefits that they hadn't had before, like dental and vision. And so these are covered up in full under Medicaid. So we're going to see perhaps that uptick in free elective procedures while they have coverage. That pent-up demand for healthcare services with broader coverage is going to couple to be a utilization spike, if you will. And are we and our providers going to have the capacities for those? So you're kind of looking at where is that population health going to go and where is it going to land? And then how long? I mean, when we look at unemployment and the effects on the economy, how long is that influx of health, that influx of membership driving to Marketplace and Medicaid going to be there before they perhaps get new jobs? So when we're looking at that, and then there was, of course, the delays we saw in folks getting unemployment. So they struggled for weeks to bridge that gap. They certainly weren't getting care there either. So it's a big, big question mark as to what that population is going to need. And is it going to be a sharp spike and then level off? Or is it going to be a sustained demand? So we're going to see that increase. So there's some interesting write-ups and papers and studies going on that I would encourage people to, when they have a moment, do some searches in the resources that they like to read, because this is where a lot of the dialogue is happening. When you look at how many Americans lost their jobs, and then how many are going to potentially be eligible for these programs, it's going to be a big shift in our market.
And that impact, so certainly a shift on the Medicaid side, on the health plan side, when you think about that potential trend, anything that the health plans are thinking about in relation to that?
Well, it depends on what a health plan is in, what market the health plan is in. If they're a commercial marketplace, they're not going to see that spike. If they're in the marketplace, the expansion population or ACA, whatever you want to call it, we're going to probably be seeing that spike. And then if you're in the government space under Medicare or more under Medicaid, you're going to have that influx. Now, the other thing that was happening as well is in some states, they had cut their rates that they paid to payers because of COVID and what they were having to fund at the state level. And so you can imagine, as any company would, you're coming along with a budget and then all of a sudden your rates are cut.
Right.
And then you lay that over an expected increase of population coming in 2021. There might be some real challenges around that. So we're basically talking population health, as a society, and where is that going to ebb and flow, and how is that going to hit capacity? One of the things that I've looked at is, we went from having a member census at a certain level, and then all of a sudden it hit rock bottom because people just weren't in the hospital unless they were COVID sick. And then right around June, it started to creep back up again. And they're like, oh, we're getting a spike. And it's like, no, not really. We're getting a return to normal. And then it kind of surged past normal as we started to see pent-up demand. But this is still in an environment where the payers are not fully open, the providers haven't thrown open their doors 100% yet.
Right.
So that's where the capacity and the demand is going to sooner or later come together, and we'll see if it comes together in parallel or if we start to have that crossover where there's way more demand than there is capacity.
Yeah,
2021 is going to be very interesting.
Indeed it is. I'm assuming, at least for some of the plans, there was some copay waivers for COVID testing.
Oh, certainly. Yeah.
And, ED visits, that kind of thing. So now we're going into flu season. How do what are you seeing? Is there a trend to back off of that because it's going to be harder to discern?
No, I'm not seeing a back off of that. The examples you saw around copays for COVID-19 related diagnoses and ED visits, we're waiving the cost sharing for medical services whose diagnosis is COVID. Also, promoting alternatives, so we waived the copays for the diagnostic, the testing, and the treatment for COVID, but also trying to promote those alternatives to ED level of care, because you don't want them going to the ED if it's appropriate to try to get that COVID testing or telemedicine or urgent care, minute clinics, call a nurse to address what their needs might be. Because you just don't want them exposed to what's going on in the EDs if at all possible, and nor do the EDs themselves want people coming in there. So, of course, if somebody has an emergency condition, that's where they have to go. But if there's any alternatives to getting care, to try to really make sure that's available for people.
That's great. So, if you had a crystal ball, obviously you're dealing with this ongoing crisis and collaborating with appropriate folks, but you're still having to do some planning down the road, right? If you had to identify sort of the key things that health plans are focused on or worried about, I guess I would ask you, what would that be? You mentioned capacity earlier. Mm-hmm. So capacity, I would think, would be one thing, but what would the top 3 maybe or 4 things be that you would be worried about going in 21 and
beyond? Yeah.
And beyond, right?
Because this has been such an impact in so many ways, what we're coming off of. Many payers are committed to solving all those gaps that we saw. We were aware that some existed, but to the extent and the deepness that gaps in access to and delivery of healthcare were really highlighted in the past 6 months, and continue to be highlighted on a daily basis. This is particularly prevalent for the disadvantaged populations, which this year's events and circumstances has brought into, the limelight. On that website that I mentioned, and there's other websites as well, I just found this listing was quite comprehensive. You'll see the depth and breadth of what the payer communities are committed to trying to do around closing those gaps in healthcare. Health plans are committed to addressing and improving that from the inner city to the rural areas of our country. Both those areas were quite hit hard by COVID and did not have that access to services that you saw in some other areas of the country. Case management as a profession has always been concerned in breaking down barriers to access And that's what we saw happening with the COVID outbreak, was a lot of barriers to access. The impact of the pandemic is going to ripple, like you said, from 2020 through the years that follow. And I think you're going to see so many impacts: social change, economic impacts, political. I won't go there. Health service delivery. Education of the next generation is going to be very interesting to see how that was impacted. Population health impacts of that delayed care that we spoke of just a minute ago. From a payer and provider perspective, we need to look at our infrastructure and our flexing on capacity. How do we optimize in such a way that it facilitates rapidly pivoting? That was one of the other things that we saw, is you had to be able to adjust, identify, adjust, and make a change very rapidly. Even from my own perspective of my company had to move 31,000 people to remote in a matter of a week. And we did it. And we did it with very few hiccups. But we were just astounded by the fact that it went as smoothly as it did, and that we were able to do that. I think as an industry, we'll of course learn and adapt from the tests that we just went through on our emergency preparedness plans, and that they had some fail points, and we need to shore that up and figure out how we can be nimble and how we can make sure that we have those things built in the future. Health plan providers and policymakers need to be open and innovative on how and where we provide care, and not get stuck in some of the red tape that sometimes we run into. We were collaborating, like I said, multiple times a week, and this can always be more robust. Health plans, not just payers. Yes, we pay claims and we provide benefits, but we do so much more in the communities that we serve. So health plans are same as providers, physicians and nurses. We have substance abuse counselors and social workers, and we also have case managers. Our case managers, we assist our members with their needs. We coordinate care, food, transportation, pharmacy, behavioral and physical health and wellness, same as case managers everywhere. So working together to coordinate that care throughout the continuum of society in hospitals and clinics, community centers, but also in the individual's home. I think you're going to see a lot more services brought to the people. I think that's a good thing. That's going to come out of this. In my experience, our case management also occurs in food pantries and under the bridges and in the churches. And we have to continue to do that innovation and remove those obstacles now more than ever. So I guess case management as a professional will always advocate for the patient, member, client, whichever your approach calls, the people we serve, and removing barriers to needed services and resources. So sometimes the challenge is the mountain. And sometimes it's looking at the top of that mountain to see what's coming down the road. So I think that's kind of where we're at.
I agree. Obviously, our constituency of this association is folks that worry about how to transition care from settings and case management. This is a sort of an off the cuff because you shared a lot of resources, but anything, I think that world is changing as well. Is the care, you said it very eloquently just now, there will be more care going to the people maybe than we've seen in the past. So any reflection or thought on folks that worry about case management, the professionals, whatever they're nurses, social workers, other healthcare disciplines, physicians who, are over care continuum, where do they need to, it seems to me they need to seek some education from all areas as they've always done, right? CMS and health plans, et cetera. But any other reflection or thought on what's going to change for them near term and long term?
Well, I think how they approach to serving their members. My TOC coaches that I have struggled with not being able to be face-to-face, not being able to go into the hospitals and see the member and actually build that relationship. There's the phone, and most folks will tell you that it's difficult to do that relationship building just primarily by the phone. So from a case management perspective, I think that is our challenge, is when we're limited to not being face-to-face. Well, how do we optimize our approach to build that relationship? Of course, video helps. Having that face on the other end brings that relationship building up, exponentially from just phone. Where can we meet members? Sometimes it's the home. Sometimes, like I said, it's the fast food place on the corner. Where are they comfortable to engage? That's going to be our challenge. And those transitions, where we were face-to-face, how can we better do those when we can't be face-to-face? I know we're all waiting, hoping we're going to get back into the field. We've sent, in my world, we've sent my staff their packet of masks, bag to put your mask in, make sure you wash it every day, and here's a case of hand sanitizer, and all the things we're trying to prep them with to get back out in the field. But we really have not. We're watching it day by day, but we haven't put them back out in the field yet. Our nurse practitioners are out in the field from a payer perspective. Our payer nurse practitioners are out in the field. Hospitals, I don't think, are ready for us to come in the door on transitions of care yet. So we wait, standing at the ready, to hopefully get back out there because, we're case managers and that's what we do. That's
great. So this, I think, perspective, Lynn, is so important, especially for the professionals who do this work. I guess as we wrap up our discussion today, what have I missed in terms of questions, or what any thoughts, comments that you would want to leave, our professionals as well as folks that, could potentially be members of any health plan, or, just folks in general navigating these difficult days?
I think probably, and the folks in ACMA who know me, know that I'm always promoting that, that care for patient and that care for member come from the same place, or care for client. You have also our folks that are out there in occupational health and workman's comp, but we're all in this together, and we all have the same objective, and that's to make sure that folks are cared for in the best way possible, and that they do get access to services, and that they do have a fighting chance with food and the ability to see their caregivers and those kinds of things that are so important in our lives. So we're all in this together. We're all working towards the same goals. So we need to reach out and make sure we're partnering. Where perhaps that hospital discharge plan or case manager's view of that patient ends when they leave the four walls, mine begins. So give me a call. Let's work together on this. As we start to look at what the impacts to quality of care were, when we look at the triple aim and some of the quality measures that we've all worked on year after year after year, this has had a very big rippling effect on that as well. So how do we make sure that we're getting in front of the right members? How do we make sure we're not tripping over each other? That's always been one of my pet peeves. Is that, that member that gets discharged from the hospital, or back when I was in the hospital setting, that patient that got discharged from the hospital got 15 phone calls in the first 3 days they were home. And then what happened? So if we can work together to take all these resources and spread them out so that we can support somebody for a longer period of time, that's always kind of been my mission. If we have everybody getting in front of the person in the first 30 days, then we pull the rug out from under them. It's like, no, that can't be the way we do this. We have to make sure that person's supported and that they continue to work towards that better outcome and managing themselves. So I think we all have the same goal, and it's let's reach out, let's collaborate, let's put our heads together when we have a barrier and come up with that innovation.
That sounds great. And I would be remiss, Lynn, if I didn't, because you illustrated it well. ACMA has established standards for transitions of care, and it speaks to exactly, the getting what the patient and family need without us as professionals tripping over ourselves or having so many voices in the arena that they can't discern what's the most important. So
Right.
that longitudinal view of how folks move through care, I think, has never been more important than it is right now. And, those resources are on the ACMA website as well. And I think to Lynn's point, it's just critical in these important days. So thank you, Lynn, for being with us today. We're very appreciative, and obviously for our audience for tuning in. Again, if you have those questions or topics for Lynn, you can submit them to acmaweb.org/podcast or send us an email directly to podcast@acmaweb.org. So again, look at the ACMA website, acmaweb.org/podcast, or an email directly to podcast@acmaweb.org. I thank everyone today. We are excited to bring you the information that we have from those who have the expertise to share with us. And again, Lynn, thank you for being one of those folks for us today.
Thank you, Deb.